Hi, this is Joanne Hayes, nurse practitioner at Alice Peck Day Primary Care and the director of the Diabetes Clinic in Primary Care. This is our second CME series. We did this series in the spring of 2023, and I'm now recording them for people to review if they missed them or for new people, new providers and staff at the clinic. The title of this and the focus of this is medical management of type 2 diabetes. We'll be focusing more on the newer medications, and then we'll do a quick review of insulin at the end as well. So the main thing that I want to review here is how we think about the treatment of diabetes. It's not just about glucose anymore. There has really been a paradigm shift in caring for patients with diabetes from a stepwise approach to really looking at a fuller picture, getting the entire story of the patient and incorporating all of that into their care. The National Health and Nutrition Examination Survey, which is part of the CDC, is looking at diabetes and cardiovascular risks, and a good percent of people are not reaching the targets of care, and more people are having diabetes or getting diabetes as well. This slide is just to point out that a majority of people that are diagnosed with diabetes are older, and therefore they're much more likely to have comorbidities. And it estimates that the diabetes and its burden in the United States is really growing over time. And if we look at traditional cardiovascular risk reduction, we're seeing that the rates of serious complications to cardiovascular risks events like stroke, amputation, and stage renal disease, the rates of serious complications have fallen, but the numbers of events have not, because the number of people diagnosed with diabetes has gone up. And it's important to also, so if we're looking at comorbidities along with diabetes, we can look at the additive component of diabetes to these other problems. And we can use the framework of loss of years. So the younger you are with diabetes, and then you add in cardiovascular disease and chronic kidney disease, it increases the possibilities of years lost. So we need to manage risk to increase life in years. And specifically looking at chronic kidney disease in diabetes, the prevalence is quite high. Diabetes is the leading cause of kidney disease, and as renal function declines, so does the increase for heart failure. There's an increase in heart failure. So we're looking at the kidneys and the heart and the whole person, essentially, when we are looking at diabetes as well. It's a multifactorial approach to risk reduction, and it's a paradigm shift. It's not just about glucose. So we're looking at glycemic management, but we're also looking at blood pressure management, lipid management, and then we're also incorporating things that could benefit these other risks, including the newer medications. So because of there's all this new data out about cardiovascular risk and how that in kidney disease and how that is an enhancing effect in lost years, we aren't just looking at glucose anymore when we're thinking about diabetes. We have to have our approach be seeing how our treatment of diabetes can also manage these other risk factors. And if we look at the current guidelines with the American Diabetes Association and the European Association, it's basically saying at the center is the person. And it says to prevent complications and optimize quality of life. And then the outside of the wheel is the components of care, incorporating glycemic control, weight, and cardiovascular management, and then also cardiorenal protection. So we're looking at all of this. And then the way the ADA looks at the approach to care of diabetes is person-centered care with the same center, with the person in the center preventing complications and optimizing quality of life. So we're looking at medical and social history and other factors that will impact treatment, and then we're working with the patient to make the decisions on care. And this is just to go back again, just a reminder from our first talk, the paradigm that we're trying to use when we're trying to manage diabetes is to get away from this treat to fail approach where we start treatment, they're getting better, and instead of at this point adding treatment and continuing down toward goal, we wait till things get worse before we add another treatment. So we are trying to shift from the treat to failure approach to the treat to target approach, where here is the first treatment, we get down here and things flatten out. So then we add here and we keep adding until we're down into this therapeutic range. And therefore we get the legacy effect and the benefit of early diabetes control. So in our first series, we just talked about the overall idea of therapeutic inertia, and now we're getting into the nitty-gritty of what are the options for us for maximizing someone's treatment in diabetes. So there are many different treatments for diabetes. It's complicated. The different treatments that target the different body systems, and some that overlap. So basically, we're just looking at the whole big picture and figuring out for that particular person sitting in front of us what makes the most sense. So we're going to go through the 2023 standards of care in diabetes put out by the ADA. They'll be putting out another one in 2024. So we'll just go through this in a stepwise or in a slow approach so everybody can understand it. These are cards that I have. So if you don't have one, please come and find me and I'll give you this. So just to look a little closer at this, so at the top of all of the management plan is diabetes self-management and education, lifestyle, and social determinants of health, because obviously these things impact all care plans that we make. And then overall thinking about cardiorenal risk reduction and achievement of glycemic control and weight management. So right at the get-go, it's saying you're not just looking at glucose here. You're not just trying to lower glucose. You're looking at the cardiorenal risk reduction, glycemic control, and weight management. And so how do we do that? So we can start by, we're going to read from left to right. So we can assess for cardiovascular disease, and that is defined as it's defined across cardiovascular outcome trials, but includes individuals with established cardiovascular disease like MI, stroke, any revascularization procedure, or the next block over right here. This is people who are at risk, and what risk is defined as can vary, but for the most part comprises of people who are over 55 of age with 2 or more additional risk factors, including obesity, hypertension, smoking, dyslipidemia, or albuminuria. So these 2 columns here are combined to assess cardiovascular risk or existence of known cardiovascular disease. And if a patient falls into these 2 boxes, the recommendation is to look at these treatments, the GLP-1s or the SGLT2s. And then again, if they're not getting to target, then you're going to add the other SGLT2 or the GLP-1, depending on where you started. So moving over to the next thing to be thinking about when starting treatment is whether someone has heart failure. And if they do, then we want to go to an SGLT2. And then over here, if someone has chronic kidney disease, and that's defined by a GFR less than 60. And then we want to be going down to the SGLT2s, and if that doesn't work, then going to a GLP-1. So we'll go to the next part of the standards of care. This is actually factoring in weight. So if obesity is a problem for the patient, then you actually want to also be thinking about treatments that lead to weight loss, or at the least do not cause weight gain. So we want to be looking at higher efficacy for weight loss. And so right over here, this is going through the highest efficacy would be semaglutide and tirzepatide. High would be dulaglutide or liraglutide, and intermediate would be GLPs that aren't listed in that are SGL2. And then you also have neutral medications like metformin and DPP-4 inhibitors. This is really just too busy of a slide, but essentially it's just looking at efficacy exactly across the top, or what are you actually trying to target? Are you targeting weight? Are you targeting cost? Are you targeting cardiovascular issues? And then what medicine would be the best match? It's hard to see in this slide, but I have a copy of this for those of you who need it, and just come to me and I'll give it to you. So let's specifically look at kidney disease when it comes to diabetes. So we want to be checking microalbumin in people yearly, and also be looking at GFR in all patients with type 2, and for people with type 1 for longer than 5 years. And one of the weak spots that we're finding in primary care and elsewhere is that even when patients have kidney disease, we aren't actually always identifying it, and therefore not putting it on the problem list, because it puts them into it makes us think differently about what treatments might benefit them if they have known kidney disease. So this is just a study looking at a group of patients with kidney disease and how many were actually identified. The blue is the undiagnosed and the red is the diagnosed. So even to stage 5, there's still 41% undiagnosed kidney disease. So this is a large study of over 123,000 patients, and we really want to just make sure at APD primary care that if someone has a GFR below 60, then we put that in the problem list so that it will help us target their management better. So given that, we're going to be talking about SGLT2 inhibitors, and their mechanism of action is to inhibits it works in the proximal tubules of the kidney to block the reabsorption of glucose back into the blood system, and that reduces blood glucose. So basically, they're urinating out glucose. There's lots of studies looking at SGLT2s with different primary outcomes, but looking at renal and cardiovascular outcomes, including death, they are quite effective medications. And just going over the summary here, bottom line is they are very effective for chronic kidney disease outcomes, in reducing progression of chronic kidney disease, and the development of end-stage renal disease. They reduce the progression of albuminuria, and also death from renal disease. And this is important to understand. So this is looking specifically at SGLT2 inhibitors if we're using them to treat diabetes or using them as kidney disease treatment or renal protective treatment. If you have robust kidney function with a GFR over 45, these medicines are still a good option for lowering blood glucose. when the kidney function goes down and below 45, and actually below 60 for some of the medications, but in general below 45, they become less effective to use in treating diabetes because the mechanism of action is to get rid of that excess glucose. You have to have a robust kidney response. So they're not good in treating diabetes or lowering blood glucose when the kidneys aren't fully functioning or functioning well enough. But they are still used for kidney disease at those lower GFR levels. So you need to know what you're targeting when you are using this medication. And then to look at SGLT2s with heart failure. Many studies looking at this with really good outcomes on reduction of hospitalization from heart failure. To get through some of these slides that, so basically, SGLT2s reduce heart failure hospitalization pretty significantly. And anybody who has a known history or is at risk for heart failure would benefit from this medication. It is important to understand which medicines you're using for what. So these basically have to, this is going back to looking at when patients have a lower GFR, using them for different reasons than for lowering blood glucose. And these are the medications and what their doses are. They come in tablets, they're oral, and they do not alone cause hypoglycemia. So practical issues with SGLT2s is there was a black box warning for peripheral vascular disease, increase in amputation, and that was removed in 2020. However, it's still important to assess patients' volume status and to consider decreasing or stopping another diuretic when you're starting these, depending on the patient's overall situation. It is expected to see a decline in GFR when you first start them and initiation of treatment, but that decline should stop after the first initial decline. And this is just going back to saying, if they have a GFR below 45, it's really not the best choice for glycemic control, but maybe for kidney protection. There is a risk for euglycemic diabetes, diabetic ketoacidosis. So it's important to stop these medicines 3 to 4 days prior to any procedures or surgery, or if someone's really sick or high risk, then stopping these medications would make sense. And because of their mechanism of action, with getting rid of excess glucose through the urine, patients are at increased risk for mycotic infections and urinary tract infections. And it's important to review that with patients prior to prescribing these. And I usually don't start them if someone's A1C is above 9 because it's just too much excess glucose going through the system. And I find that if their A1C is above 9, then they fail treatment because they have too many side effects with mycotic infections or urinary tract infections. So let's switch here and talk about the GLP-1 group of medicines. They actually have many mechanisms of actions affecting many systems. So they are a powerful option for lots of reasons, depending on what's happening with the patient. They work in, again, this is just reiterating, they work in many different parts of the body with differing effects. And so depending on what a person's comorbidities are or their weight or other issues, they could be a good or not good match for that patient. There are many formulas of these medicines and it can be confusing. They have different delivery mechanisms. And but the main point in this slide is actually that they are quite a robust group of medicines with pretty big movement here in overall diabetes control measured by the A1C. And the GLP-1s have this is looking at lots of different studies, and they have a very good outcome with cardiovascular risk, reducing overall cardiovascular risk and cardiovascular death and all-cause death. It depends on what was measured in the study, but essentially liraglutide, semaglutide, and dulaglutide are very powerful GLP-1s when it comes to cardiovascular issues. Oops, sorry, I didn't mean to go past that, but essentially this is just to point out that the oral semaglutide does not seem to have as robust cardiovascular benefit as the injectable. It was safe, cardiovascular safety, but not the same benefit. And there's also a newer player on the block here, which is a dual agonist, that tirzepatide, which is a dual GLP and a GIP. And because it's dual, it does have pretty robust response. It's been well tolerated and works in the same way. It also has a very robust response on A1C. You can see here, and a really robust response on weight. And I've had several patients who have done quite well on this medication. The cardiovascular benefits are thought to be the same on tirzepatide, but those studies aren't quite out yet and not expected to be out until 2024. So the practical issues of prescribing a GLP-1 agonist, first of all, you have to rule out that they don't have a history of medullary thyroid cancer. It's very rare, but I need to ask for that. Or a family medical history of multiple endocrine neoplasia 2, also very rare. And then pancreatitis, that's sort of a question. Actually, patients with a history of pancreatitis can use these medicines, but not if the pancreatitis is an ongoing issue for them. So if the issue that caused pancreatitis is still existent or they have chronic pancreatitis, then this would not be a good medication for them. And it's also okay to treat for people who have had a partial pancreatectomy. You just kind of have to watch to see how they respond. The side effects of these medicines are mostly GI related. It's slowing gastric emptying, which can lead to nausea. And so I usually advise patients do a lot of education around how to manage these medications and manage expectations. I advise people to not eat too satiety, to eat small amounts of food, and tell them that this medicine is going to be affecting their understanding of cravings and fullness, and they have to kind of pause and listen to their brain and say, oh, I'm actually not hungry, even though I'm used to eating at this time. Maybe I don't want to. And we do slow titration of these medications. So when you're trying to choose between a GLP-1 or an SGLT2, this is just a good way to think about which one might be better, a better match for the patient, depending on that patient's history and comorbidities. And this is just to review what they look like. If someone is needle phobic, they might want to go with tirzepatide or the Trulicity because they don't see a needle. It's just an auto injector and they throw the whole thing away. Whereas the semaglutide is you put a needle on a pen. It looks very much like an insulin pen, and then you dial the dose. these medicines are really expensive. They're crazy expensive. So we do have to think about whether a patient can afford them. And that's part of our assessment when we're deciding on medications with patients anyway. And if we do think that this could be a really good match for a patient, but they can't afford them or their insurance copay is too much or not covered, then we could look into drug assistance programs, and Carrie is very helpful in doing that with patients. Okay, that was SGLT2s and GLP-1s, and now we're going to switch. We're going to switch and just do a quick review of insulin. The main reason I wanted to do a review of insulin is because when I see patients, I hear lots of stories about how people are using insulin, and it's kind of all over the map. So I think it's important that we kind of dive in a little bit and review this information, and also to make sure that we're reviewing it on a regular basis with patients. So essentially, we're starting with a basal insulin, would be the first insulin that we do with a patient. You can start at 10 units, or you can do 0.1 to 0.2 units per kilogram. And then you titrate based on fasting blood glucose, usually looking at trends over 3 days and then going up by 2 units, depending on what your cutoff point is. I usually set a cutoff of fasting above 140 or 150, depending on the patient. And then they would, 3 days in a row, then they increase by 2 units. So again, looking at trends. If that's not enough, then we can usually add in a mealtime insulin. I always start with just the biggest meal of the day. Again, you're starting at a low dose with mealtime insulin, usually 4 units or 10% of the basal dose. And then you titrate based on postprandial glucose. So what I usually say to patients is you learn backwards in insulin when you're treating insulin. So we want to see how you respond to a meal, and then you can't do anything about it. It's already done. So we want to learn for the next meal. So essentially, especially when people are running really high, I say, well, what I want to see for the mealtime is if you test before and 2 hours after, those readings should be about the same. And that means that you had good coverage of the meal. If the postprandial, the 2-hour postprandial is a lot higher, then the mealtime insulin wasn't enough. And so that's a good way to adjust it. Sometimes the postprandial insulin plummets, not because of the amount of the prandial insulin, but because there's too much basal on board. These are just the different types of insulin and their actions, onset and peak and duration. And this is just a graph of looking at this. It's really good to review this with patients. And the thing that I want to point out here is this ultra long acting insulins here. I use these a lot because the long acting insulins, which is like Lantus or Levemir or Basaglar, I find there's quite a bit of variation for patients, and often I'll see patients who are taking 2 doses, Lantus twice a day, but then we get stacking of insulin, and it gets kind of confusing. So I often find doing the once a day ultra long acting to be a good option for patients. This is again terms to know when you're talking about insulin: onset, peak time, and duration. And then when insulin is better targeted, we have fewer side effects from the insulin. So fewer episodes of hypoglycemia and less weight gain if we can target that insulin well. And this is just to remind you about overbasalization. Sometimes when we start adding mealtime insulin, we need to back off the basal insulin so we can give enough room for the mealtime insulin to work. I don't usually back off initially. I kind of do this in, I start seeing first how they respond to the initial extra dose, and then I'll back off in order to increase the mealtime insulin. If someone is on 3 prandial doses daily plus a basal. Usually for most people, that ends up being about a 50-50. So 50% basal insulin, 50% prandial. There's variation there, but that's a good guide to use. This slide is really to point out that as we age, how we manage glucose also changes, and our contribution of elevated glucose has to do more with prandial glucose excursions because we're not getting a good response in the body and how to manage that. So as people age, we might be shifting their basal insulin to daytime instead of taking it at night. See if we can get a little more coverage, or really focusing on the prandial insulin. And so just an overview of what to review with patients about insulin. Know how much insulin they're on and how to adjust it, when to take it, review hypoglycemia and how to treat it. If a patient has hypoglycemia, then we need to be changing their therapy. And then at every insulin, asking patients, how much insulin do you take and when do you take it? And this is important for providers to review because we hear really different stories. And what is listed in the medication list is not what patients are doing with insulin. Many times I hear about patients taking their prandial insulin after their meal, so then they have a mismatch in their glucose rise to the timing of the insulin peak. And then often patients are taking extra prandial doses throughout the day, bedtime, to bring down their glucose. So those are tricky things to adjust if people are taking extra doses, and how do we manage changes when every day is a little different. So I do a lot of work with patients around sort of simplifying their regimen, and then we make changes from there. But it's important to gather that information from patients. Really important to review hypoglycemia because it has many effects on the body, and I really kind of set that as number one goal, is to avoid hypoglycemia. And then treating sorry, I missed a slide there, but treating hypoglycemia, you start with 15 grams of carbohydrates, which is basically a couple of glucose tabs or 5 lifesavers. Half a glass of orange juice or sugared soda are good things for patients to have. It doesn't mean that they need to eat 3 Snickers bars, but usually 15 grams of carb and then checking again. And this is just a quick review of where to inject insulin, and then also to look at the needle size. I like to do the 5/16 needles. I feel like the 5/32 are so short that sometimes they keep out where people are injecting their insulin, but that's personal preference. There's a close-up of the needle size. And insulin is now a covered medication for patients since January 1, 2023. The Inflation Reduction Act in Congress was passed, which included managing the cost of insulin. And specifically what it says is that insulin should not cost more than $35 a month. Still quite a bit of freedom within the insurance industry to decide what insulins are covered, because the bill says if the insulin is on the formulary, then it cannot cost over $35 a month. So the insurer decides what's on the formulary. But I have seen not a lot of changes here. So usually there's at least 1 to 2 basal insulins and 1 to 2 prandial insulins that we can choose from within that formulary to get the cost down for patients. And that's it. That's our review of medications. Sorry about the speed here. I hope it was helpful. If you have any questions, please come find me, Joanne Hayes, and we can review things.